In this video, I am going to discuss the management of sepsis with regards to timing consideration during its initial management. It means when to do what or when to do each intervention during sepsis management and how temporal profile of initial management of sepsis looks like. I am Dr. Sunil Garg from Essentials of Acute Care, and in this video I have divided timing consideration into three: immediate, early, and others for the ease of understanding. With regards to intravenous fluids, it falls under the category of immediate. Balanced steroid should be started immediately on recognition of sepsis, septic shock. Guidelines recommend the administration of at least 30 ml per kg of IV crystalloid fluid to be given within the first 3 hours of resuscitation if patient with the known or suspected infection manifests hypotension and or an elevated lactate. With regards to blood culture, it should be taken immediately on recognition of sepsis, septic shock, and before administration of intravenous broad-spectrum empiric antibiotic. Cultures of other site should be taken as per clinical presentation. For example, take respiratory sample if pneumonia is suspected. Cultures from other site other than the blood preferably should be taken before antibiotic administration if it does not cause substantial delay in antibiotic administration. In terms of administration of antibiotics, if sepsis is confirmed or there is high suspicion of sepsis, broad spectrum empiric antibiotic should be administered irrespective of whether shock is present or not. When sepsis is possible, means sepsis may or may not be present and patient is in shock. Administer antibiotics immediately and evaluate patient further for the diagnosis of sepsis. And another condition, when sepsis is possible, means sepsis may or may not be present but patient is not in shock. In such condition, evaluate the patient and decide preferably within 3 hours regarding presence of sepsis. Administer antibiotics in such patient immediately if concerns of the infection persist at the end of 3 hours or diagnosis of sepsis establishes. With regards to use of norepinephrine in patients with septic shock, it should be administered early in the management of septic shock to achieve the mean arterial pressure goal of 65 mm of mercury faster and to decrease the risk of fluid overload. Physicians should not wait until fluid resuscitation is over. With regards to use of vasopressin in septic shock, administer it if the dose of norepinephrine reached more than 0.25 microgram per kg per minute and mean arterial pressure goal is still not achieved. Guidelines suggest to combine norepinephrine with other vasopressors such as vasopressin with the intent to raise the mean arterial pressure to target or to decrease the norepinephrine dosage. With regards to use of hydrocortisone in septic shock patients, guidelines recommend adding hydrocortisone to septic shock patients who require a vasopressor with a dose of norepinephrine equivalent to or more than 0.25 microgram per kg per minute for at least 4 hours. Lactate measurement should be done as early as possible during the management of sepsis, septic shock, and preferably within 1 hour of its recognition. With regards to source control, it is defined as surgical and non-surgical interventions used to treat an infection. When source control should be done, it is suggested that it should be done as soon as logistically and medically possible after a diagnosis of infection which is amenable to a source control procedure is made. The goal is to eliminate the source of infection, control ongoing contamination, and restore pre-morbid anatomy and function. Here I finish. Thanks for watching this video. I would appreciate your feedback, suggestions or comments. Till then, bye and take care.